thank you so much for taking some time to sit down today. And we're here to have a discussion about malignant histiocytosis, as I understand that you both were authors on a recent publication. And I'm very excited to speak on this because malignant histiocytosis, I think, is understudied and underdiscussed historically. And so it's wonderful to see the amazing work that you all are doing to continue to uncover information about this condition and to help the people that are diagnosed. And so both of you are here to talk about this from the pathology perspective, which is a really exciting conversation. So I'd love for you both to introduce yourselves, and then we have some questions to go through today. So maybe just share a little bit about where your institution is, and very briefly how you got involved in histiocytosis research and work. Dr. Rech, we'll start with you.
Thank you, Deanna. I'm Dr. Karen Rech, and I'm a hematopathologist. I work at the Mayo Clinic in Rochester, Minnesota. And here at Mayo Clinic, we have a histiocyte working group that's multidisciplinary, and we all get together and discuss histiocytic patients, and all of them are very rare, but these include Ernheim-Chester disease, Rosai-Dorfman disease, Langerhans cell histiocytosis, which are more chronic indolent diseases, and then the more aggressive malignant histiocytoses, which is what the current paper that we're going to be discussing is on today.
Thanks, Deanna, for having us here. I'm Aishwarya Ravindran. I'm an assistant professor of pathology and a consultant hematopathologist at the University of Alabama, Birmingham. My journey in histiocytosis world started when I was a research fellow back at the Mayo Clinic in 2015 under the mentorship of Dr. Ronald Go. And subsequently, when I started my residency over there, I trained with Dr. Rech in histiocytosis and developed a special interest in this area. And I continue to do my projects in histiocytosis, including Ernheim-Chester disease, Langerhans cell histiocytosis, Rosai-Dorfman disease, and recently malignant histiocytosis. I'm excited to talk about our paper. And yeah.
Thank you so much. I'm really eager to dive into the paper, and I'm going to share the title here in a second, but I actually wanted to really quickly highlight the working group that you two mentioned. So Dr. Rech and Dr. Ravindran, you are part of this working group between Mayo Clinic and the University of Alabama at Birmingham. Can you just share very briefly the benefit of that group and why it's so unique and powerful?
Yeah, so the group started here in 2017, I believe, and initially it was a very small group of physicians led by Dr. Go in hematology, who all had an interest in these rare diseases. The histiocytoses are very difficult to diagnose if you're only looking from one perspective. So if we only have the pathology, the features are nonspecific, and if we don't know anything about the patient, it's really hard. There's a lot of differential diagnoses that come under consideration, and it's hard to come to the conclusion that it's a histiocytic neoplasm if that's all you have. So the original group got together so that we could all learn from each other and put all the pieces together, from the pathology, from the radiology, from the clinical perspective. Histiocytoses, they can present to multiple different disciplines because they present in multiple different organ systems. So it's a hematologic malignancy, but it involves the neurologic system, the endocrine system, cardiology, pulmonology, and it has very characteristic radiologic findings. So this group, over the years, we've been meeting on a monthly basis to discuss these patients, and all of us have learned so much from each other, so that if we have a case that presents in any of these disciplines, we have this group that we can refer to share the cases and say, ask, what, from your perspective, does this look like a histiocytic neoplasm or some other disorder? And so we've all gotten a lot better at recognizing these cases and diagnosing them, which is extremely helpful for these patients because they go from an ill-defined chronic illness that nobody can define to a diagnosis that has a specific genetic mutation, oftentimes that's targetable by specific therapies. That we have now 2 that have been FDA approved for these disorders and really made a difference in the quality of life for these patients.
And I think also through this group, in addition to the clinical discussions monthly, we also have multiple clinical, translational, and some basic science research that goes on in the realm of histiocytosis. We have multiple team members working on various different projects at one point in time. I think this paper that we're going to discuss about today is one of those products of those multidisciplinary teamwork. And not only this, there's also a clinical paper that talks about malignant histiocytosis, clinical characteristics and outcomes. It's also a product of this group's work. So there is multiple ongoing studies along the research side as well.
Thank you. Yes, that's very powerful. I mean, it's amazing to see what comes out of that, and the collaboration is just astounding. So thank you so much for your passion for this and for being a part of this collection of colleagues who are focused really at pursuing all angles for histiocytosis. And I know that this paper is also very exciting to have this information. It's definitely going to leave a lasting impact on the future of research, as well as be able to really influence right now as well. So the title of the publication is Malignant Histiocytosis Compromises a Phenotypic Spectrum that Parallels the Lineage Differentiation of Monocytes, Macrophages, Dendritic Cells, and Langerhans cells. So Dr. Rech, would you mind sharing a little bit about the concept behind this paper?
So malignant histiocytosis has been sort of a diagnosis that is a last consideration. So these cases are very rare. And so when we get a biopsy from a patient that shows features that could be malignant histiocytosis, there's a lot of other things that are in the differential diagnosis, which are much more common. So you have to rule out melanoma, carcinoma, sarcoma, and then if those things are all ruled out, lymphomas, if you all rule out those things, then the last thing you consider is malignant histiocytosis. Over the years, our ability to phenotype these neoplasms has improved. We have more immunohistochemical markers available that we didn't have before. So we have more lineage-specific markers that we can use for malignant histiocytosis. And so the idea, the concept behind this paper was to take a look at a series of these cases and comprehensively phenotype them so that we can know what's the best panel to use for IHC to work up these neoplasms and to confirm a diagnosis. In the literature, cases of malignant histiocytosis are very limited, mostly case reports, and so it's hard to get a full picture of the spectrum of disease. So this was to define the spectrum of disease, and also to bring them under one subset of cases, so one umbrella. So malignant histiocytosis is an umbrella term, and it includes the WHO diagnoses of histiocytic sarcoma, interdigitating dendritic cell sarcoma, and Langerhans cell sarcoma. In the current WHO classification, these 3 entities are described very separately. So one of the concepts that we wanted to bring across from this manuscript was that they are all related, actually. So they're a spectrum of disease, and they're not distinct entities. So there's a lot of phenotypic overlap between these different diagnoses, and it may not be critical to put it into one of the 3 discrete categories, but the most important thing is to recognize that it is an example of a malignant histiocytosis, because they all have similarities in terms of the differentiation from the myelomonocytic lineages, and then they often have mutations in MAP kinase pathway genes. So they all have the same pathogenesis.
Great, thank you. And so, Dr. Ravindran, maybe you can build on what Dr. Rech just shared and talk a little bit about some of the key takeaways from the work that you've done and how they're illustrated in the publication.
Absolutely. So we took about 22 cases in our cohort. We went back into it's a single institution studies, and those cases that we have reviewed over the years. I started this manuscript when I was a trainee back in 2019. It took us nearly 3 to 4 years to bring it to completion and into a manuscript product. So what we did in this 22 cases, we revisited the diagnosis. We confirmed the diagnosis as malignant histiocytosis. We applied a panel of immunostains. Immunostains are nothing but antibodies. We apply it on the tissue to identify a protein that is expressed by the cells of interest, in this case, the malignant cells. And based on the pattern of the immunohistochemistry or immunostain expression, we categorize them into 4 different groups. One is the macrophage phenotype, one is the monocyte macrophage phenotype, the third one is a dendritic cell phenotype, and the last one is a Langerhans cell phenotype. And what we are essentially, when we're grouping this to in this kind of subcategories of based on our immunostain expression, we're trying to correlate them how these cells arrive from the parent cell, the myelomonocytic lineage of the mononuclear phagocyte system. We are trying to see how these malignant cells are actually derived or developmentally related to their primary cell of origin, which are your mononuclear phagocyte system composed of monocytes, macrophages, dendritic cells, and Langerhans cells. And these cells are part of your normal immune system. The way I see this is these cells can acquire genetic mutations and they can transform to cancer causing or a malignancy. So that is a concept about like applying this immunohistochemistry here. And secondly, what we are looking into in these cases is like how many of these cases are primary, which means de novo, they don't have any other history of prior cancer. How many are de novo? They are arising just by themselves because of a genetic mutation that is acquired, and these can present in any tissues. And the second cohort is how many are secondary. When I say secondary malignant histiocytosis, they typically relate to a history of lymphoma in a person. Sometimes the lymphoma that is present, over time, what happens, the lymphoma can change its lineage and become a histiocytic lineage. And this is called a transdifferentiating malignant histiocytosis. And we discuss about 8 cases out of the 22 cases in our paper about what is their prior history of lymphoma and how those malignant histiocytosis are related to the prior lymphoma. And we also discussed the phenotypes that is in the secondary malignant histiocytosis cohort. And interestingly, the macrophage phenotype, it's not present. Majority are monocyte macrophage, dendritic or Langerhans cell come under the secondary cohort, as opposed to the macrophage cohort of malignant histiocytosis comes under more in the primary and de novo only cohort. So we discussed these various phenotypic variations amongst the subtype, and right now we don't know what these subtypes means in terms of treatment and outcomes. That we need to gather more data and more studies to for us to recognize the significance of these various subtypes under the umbrella of malignant histiocytosis.
It sounds like a very important work that you've done, and just to have this information is amazing. I mean, I know that malignant histiocytosis, I'm learning so much more about it every day, and we are interacting with more people who are being diagnosed, and there is still so much that we're learning. So to be able to recognize these different subtypes is incredible. Um, on that subject, subtyping in in these categories of malignant histiocytosis, does it have any impact on treatment, or what's the impact that it could potentially have?
At this point, we are not really certain if the subtyping, if one subtype versus the other subtype of malignant histiocytosis performs better than the other, because a cohort itself, it's a rare disease, and I would consider this malignant histiocytosis to be rarest of the rare disease cohort of histiocytosis itself. Um, we need to gather more data as we go along when we see these cases to see how each of these cases perform in long term. And I believe the clinical paper from our histiocytosis group titled Clinical Characteristics, Molecular Alterations, Treatments and Outcome of Malignant Histiocytosis it provides more insights into treating these malignant histiocytosis, whether there is any difference in terms of the subtype of these categories. But I do think we need more data before we can tease out reliable conclusions. And so it is for primary and secondary malignant histiocytosis as well. We automatically tend to hypothesize that, oh, secondary malignant histiocytosis, they are arising from a prior malignancy, so they do worse significantly when compared to primary. But that is not the case. We still need to gather more data on this realm before we can conclude that secondary is worse than primary. At this point, we just don't know these exist, and that's what I paper. The main significance is that we need to recognize these entities. We need to follow up these cases, and then long term down the road, prospectively, we can see like how each of these perform according to their subtypes.
Phenomenal. So it sounds like you have a plan for what's next, and you know where you want to continue to investigate, which is I can't wait to follow up with you and to see what you learn. So, to think about potential impact in the future, Dr. Rech, maybe we'll turn to you. Where do you see this having impact, thinking a couple years down the line for patients and also for your colleagues, as they either study or treat malignant histiocytosis?
So our histiocyte working group is really important in order to translate what we learn in pathology to treatment options for the patient. So I think historically, establishing the diagnosis has been the biggest challenge. And if you can't establish a consistent diagnosis for these patients, then it's really impossible to learn anything about how they respond to treatment and what type of treatment might work for one patient versus another, because you don't even know if you're treating the same entity. So the cohort that we had was supplemented with some additional patients on the clinical side, and our clinical group published in February of 2024. Recently, they published in American Journal of Hematology the clinical characteristics of these patients and therapies that were tried for these patients and how they performed. So I think now that we have a consistent workup from the pathology side, we can continue to gather more patients that are well characterized and confidently diagnosed. And so we can brainstorm what types of therapies can we try for these patients and determine what are going to be the clinical outcomes that we're looking for, and really gather the quantity of data that we need to draw significant conclusions. So I think that these patients, it's so rare that in many locations the clinicians don't know how to treat these. So if we can establish the diagnosis, get them to a treatment center where people have experience treating these disorders, that's going to make real progress toward a better outcome.
I couldn't agree more, and I know this will also have a ripple, around the world, because we do see patients diagnosed all around the world with malignant histiocytosis, and I think the awareness of how to treat is equally as limited everywhere you go, just because it is so rare. So the fact that you're making, inroads to help with diagnosis of this, and then also on the clinical side, there's work being done to look at how to best treat. It really helps set a great experience for patients, because there's information also for providers to reference. So I really appreciate that you're doing this and that you're pushing this forward. It's so important for patients, and this is kind of what leads to clinical guidelines in the future, and you're really helping to make that happen. So thank you so much. Is there anything else that you'd like to share about the publication or anything that you feel we've missed in our conversation today?
Just one thing I wanted to add about the paper itself, and also something that is relevant to practice in pathology as well as clinical, is that a paper helps it's a resourceful guide for referring to what immunostains to perform to categorize these as malignant histiocytosis. But the most important thing to be aware for pathologists is that we need to triage tissue for next generation sequencing, because that is going to be the most important piece for clinical treatment to identify any targetable mutations that is present on the tissue. So oftentimes, sometimes it's a core biopsy or sometimes just like a small portion of biopsy, we get into the dilemma of like, oh, what study should be prioritized first? So I would say like we need to really prioritize the most important stains to characterize the lineage that it fits to the histiocytic lineage. And the second, the most important priority that should be kept in mind is triage tissue for next generation sequencing. Frequently, a comprehensive next generation sequencing should be performed in these cases so we can identify any mutations. Majority are related to the MAP kinase pathway, but a minority may be related to the other pathway that could be targetable with the available therapies, or sometimes they can use drugs that is off label depending upon the relevance of mutations to this diagnosis.
Thank you so much. I appreciate both of you for generosity of your time and sitting down today to talk about this really important paper. And I also just want to applaud you and the working group for everything that you're doing to help patients and families and your colleagues around the world to better diagnose and treat these very rare conditions. Thank you so much, and I look forward to following up with you as you continue to learn more.
Thank you, Deanna.
Thank you, Deanna, for having us.